Good evening, everybody, and welcome to IF Oxford, the Science and Ideas Festival. I'm now going to introduce you to Oliver Evans from the National Institute for Health Research. He's going to give you a little bit of information about the organisation and what it does before passing over to tonight's speaker. So over to you, Oliver.
Yeah, good evening and welcome to our talk, Pelvic Pain, Diagnosing Endometriosis Sooner. And the NIHR is really the government's research funding arm. We spend about £1 billion a year on all types of research, and that's from laboratory-based science to studies taking place in the NHS and in hospitals, such as Christian's research, which is what you're going to hear about tonight. And the goal really is to improve the NHS, but also public health and social care through research. And you may have heard the NIHR mentioned in all the news coverage around the COVID-19 pandemic, and our research really has been at the forefront of the response to the pandemic, from the prevention through things like vaccines, through to diagnosis and also treatment. And so you can learn more about research and how you can take part in studies, even if you're healthy. We're always looking for healthy volunteers for studies at the Be Part of Research website, which is bepartofresearch.uk. If you just search Be Part of Research, you should be able to find it. So I'm delighted to be joined by Professor Christian Becker, who is an Associate Professor at the University of Oxford's Nuffield Department of Women's and Reproductive Health. So over to you, Christian.
So today's talk is about diagnosing endometriosis sooner. Just as a disclaimer before, obviously I will talk about endometriosis and women, but I also mean individuals, to be fully correct. So anyone who has, I guess, a uterus and fallopian tubes and ovaries could have endometriosis or could develop endometriosis as well. The other thing, there will be a few pictures and a short movie as well from an operation. So it may not be to the taste of everybody. And I'll try to warn you before, but I don't think it's too gruesome, so it should be fine for everybody. All right. So let's see whether this works. All right. So I work here in Oxford at the University of Oxford in the Endometriosis Care Center, which is a large tertiary referral center for endometriosis, and it's a collaboration between the University of Oxford and they're the Nuffield Department of Women's and Reproductive Health, and the University Trust here, the NHS Trust here at the Dramatic Hospital, and other hospitals as well. But as I said, I'm part of the team. This really only works when you work together very closely with all different type of people. As you can see here, our nurses play a very important role. We have specialist endometriosis nurses as well. There's the surgical team, there's the researchers. And from a research perspective, I co-direct the Endometriosis Care Center together with Professor Karina Zondervan, who you see down here on the right lower panel in the blue shirt, who's also the head of department in our here in the university. And I lead the clinical setting in the trust as well. So I'm not certain whether everybody is familiar with the term endometriosis and what it is, and that's why I'm going to give you a little bit of an introduction there. So it is a chronic inflammatory condition, and it is the presence of the endometrium or endometrium-like tissue outside of the uterus. Now, the endometrium is the uterine lining. As you can see here on this picture, you can see a picture of a uterus cut in half, and the inside of the uterus, the uterine cavity, contains the endometrium. That's the lining that women usually bleed out every month. That's where the name endometriosis comes from, because endometriosis tissue is very similar to the uterine lining tissue. This is what it looks like under the microscope. And it's an estrogen-driven disease, which also explains why the majority of endometriosis is found in women during their reproductive age. So between the onset of their first period until menopause, although some women may suffer from the symptoms even afterwards as well. It is a major cause of pelvic pain, with painful periods, for example, pain during or sexual intercourse, pain emptying your bowel or bladder, fatigue, and other symptoms as well, depending on where these lesions, these endometriotic lesions, are found. They're mostly found in the pelvis, but theoretically they can be in other places in the body as well, although this is relatively rare. Endometriosis is also associated with fertility problems in some women. So I'm not going to talk about this in more detail today, but I'm sure if you have any questions, I can answer those. In general, treatment for endometriosis is either the surgical removal of the lesions, either by cutting it out or burning it away, or with hormonal suppression, which includes, for example, contraceptives, progesterone in different forms, or injections that really suppress the ovaries and therefore suppress the production of estrogen, which again is the stimulus for endometriosis. Now, the problem with that is that these approaches have a lot of side effects. They're often not sufficient, so a lot of people are not much better, or only or not better at all. When it comes to the hormonal suppression, most of these medications are contraceptive as well. So if someone would like to become pregnant but is also suffering from endometriosis associated pain, then hormonal suppression is usually not the right approach. On the other hand, if you think about surgery, it's an invasive procedure. There are small but surgical risks involved, and surgery itself can cause scarring, which may have other implications as well. The other problem is that no matter what you do, there is about a 50% recurrence rate within 5 years. So we usually consider endometriosis as a chronic disease in these women and individuals. So where does it come from? I think the easy answer is we don't fully know. So this is a picture here of a uterus schematically, and you can see here the uterus and a fallopian tube, and then a small picture of an ovary as well. So on the inside of the uterus, again, you see the uterine lining, the endometrium, and this gentleman up there, Dr. Sampson, he described for the first time this theory that endometriosis may come from retrograde menstruation. So when women have a period, the blood may not only go down the normal way through the vagina and out, but also enter the abdomen, so the abdominal cavity, retrogradely, so backwards through the fallopian tubes into the abdomen, and then may attach there, because there's not only blood there, but there's also cells from the uterine lining. The problem with that theory, though, is that probably every woman who has a period also has some form of bleeding backwards anyway, but not everybody gets endometriosis, so there must be other factors involved as well. And this is something that we are very interested in exploring further, which is also very important to really improve our way of diagnosing endometriosis, but also of treating it if we better understand the mechanisms behind it. So as I said, one hypothesis is this retrograde menstruation. Other possibilities are that the hormones play a role. Maybe it is a problem with the immune system, that some women have an immune system that doesn't work as well, and therefore the blood that goes into the abdomen each month anyway is not cleared sufficiently. There may be genetic factors, there may be environmental factors as well, but nobody fully understands the whole process yet. And sorry, I did not warn you, so this is the first potential gruesome picture, but I wanted to show you what endometriosis actually looks like. So these are pictures from the abdomen which we've taken during a laparoscopy. Here on the right upper panel in the background, you actually see a uterus, and this white thing here is the left ovary. But as you can see, this small black dot here is a beginning ovarian endometriosis cyst. Currently it's superficial, but it starts to invade the ovary. On the left upper panel, there is something on the wall of the uterus. And again here on the left lower panel, same thing, but you can see it looks very different to the upper one. And again, the same thing on the right side, where you see a lot of blood vessels growing towards an endometriosis lesion, which shows signs of inflammation, which is a common feature in endometriosis as well. So as we're interested tonight in the diagnosis of endometriosis, what can we do? Well, obviously, when we see patients, we should take a very thorough history and ask them about the symptoms that they've been suffering from. We usually would examine them as well internally, similar to a smear test if appropriate, and the patient is old enough for that. There are various forms of imaging, which we'll talk about in a second, usually an ultrasound scan or in some cases an MRI. And then there is laparoscopy, which is keyhole surgery. So these are pictures of ultrasound scan, and as you will see in a second here, so on the lower part, this black thing here is the bladder, and the darker gray thing behind is the uterus. And you can see here on top of the uterus, there is what we call a nodule. And when you move the probe inside around, you can see how this does not really move very much between the uterus and the bladder. And this nodule on top there, it just stays on top. If you see the other movie, here again, same thing. You see a uterus and the bladder, and you see how it very nicely shifts against each other. So there's no indication that there's anything stuck together or any sign of endometriosis. So that's just an example of what we're looking for when we do usually an internal ultrasound scan. This is another picture, just a still picture of an ovary, which contains a very large or relatively large endometriosis cyst. You can see it's about 11 or 10.5 centimeters with a typical ground glass appearance. So that's what we see sometimes on ultrasound scan at different sizes. The ovary actually is more or less used up by this cyst inside. So there's not very much left of the ovary, and the cyst takes over most of the ovary in this picture here. And then there is something called biomarkers. So could we, ideally, if we could take a blood test to tell us whether someone has a high risk of having endometriosis with certain symptoms, or if we could rule it out, that would be fantastic. Now, you don't have to memorize all of this on here, so don't worry, I'm not going to do a quiz at the end, but this is just to show you that there is a huge number of studies out there that have looked at different biological and molecular markers in endometriosis. But unfortunately, when we reviewed this a few years ago and really looked at, how good is the evidence that this is a good and reliable biomarker, so a biomarker that would tell us, yes, you have endometriosis, or no, you definitely don't have the disease. There's nothing out there that we can use clinically at the moment. So again, another picture. This is actually a small movie, so if you want to look away, this is about 50 seconds. And this is during a laparoscopy, so keyhole surgery. And what you will see here in the middle is the uterus again. The thing that's moving is the large bowel. And you can see here the blood vessel is pumping, so this patient is definitely alive. You can see the liver looking up on one side. And again, we look around. We have a very close look at the abdomen just to make sure there's nothing else here, and the liver on the other side. So now we're in the pelvis. And what we're doing now is we're lifting up the right fallopian tube. And then there's a small cyst at the end of it, but a clear cyst. And then there's the right ovary right next to it. And then we have a look into the pelvis and make sure there's nothing in there as well. No spots of endometriosis that we've seen before on the pictures that I showed you. This is the pouch of Douglas, which is the lowest part of the abdomen. And then on the left side, the same thing. We again have a look at the fallopian tube and the ovary. And in this patient, there was not very much found really. So this was a patient who came through with, excuse me, pelvic pain, but we didn't have, any signs of endometriosis. And again, if we had a lovely biomarker that would have told us this before, we could have avoided surgery in this patient. Sorry. By the way, this is not COVID, and I don't think anyone has ever been infected via Zoom anyway. So these are pictures, again, of endometriosis. And what I want you to understand here is that endometriosis has many, many faces. So in the upper panel here, you see very tiny spots of endometriosis, those white arrows. Here you see a red lesion with a lot of blood vessels growing there. Here on the right side, you see an ovary where we're just opening the cyst on the inside. And you can see this brownish, gooey stuff coming out, which is an endometriosis cyst. So this is old blood that has been in there for quite some time, produced by endometriotic tissue that underwent the same changes as normal lining. So each month there was, in a way, a period inside of the ovary, but it couldn't go anywhere. And that's why the ovary ballooned up and created this cyst. It's also called, excuse me, a chocolate cyst because of the color sometimes. And here, again, you see small superficial lesions. What actually lies behind here is a big nodule, so deep disease. And sometimes that's why you have to really have someone with experience to look at, to ensure that there's nothing lost or missed here. And up here, this is a picture of a uterus where both ovaries are stuck. You can see this very nicely, very strongly stuck in the bowel as well. Now, what I want you to take away from this is that we consider this as one disease, which probably it isn't. And that's one of the issues that we have when it comes to diagnosing, but also for treatment as well. So if you think about diagnosis, this is a study that was done here in Oxford by my colleague Karina Zondervan before we worked together, which showed that it's very normal that patients see a lot of GPs before they are actually referred. And there was an average of about 7 years from the onset of symptoms until a final diagnosis was made. And that was very, very typical for a lot of patients in the UK. And the same is true for other countries, which I will show you in a second. So as a result, patients are suffering for a very, very long time. And that's one of the reasons why endometriosis has a significant impact on not only the individual and their families, but also on society and economy as well. So we know that approximately 10%, up to 10% of women during the reproductive phase have endometriosis. And if you extrapolate this onto the world, about 190 million women worldwide, or individuals worldwide, are affected by the disease. In the UK, that would translate into about 1.5 million. Now, if you look at it purely from a cost perspective, it is very, very similar to other major chronic diseases, such as type 2 diabetes or rheumatoid arthritis, which is quite interesting. Again, delay in diagnosis. So not only in the UK, but anywhere you live, there's a significant delay, and it ranges somewhere between 7 to 12 years in the different countries and areas in the world. So it is definitely a poorly understood and under-recognized disease. Every once in a while, you see that the press picks up on this. This was from a actually ongoing story from the Guardian, but other papers have done this as well, where every once in a while you see women talking about their symptoms. But the problem is that endometriosis is not a disease that people would like to talk about, because it has something to do with, with reproduction and with periods and so on. So it is not anything that is so well accepted in society, unfortunately, yet, that people can do freely talk about it. And that is really one of the problems that we have, that women have, which is one of the reasons why there's such a delay in diagnosing it. Other thing, it's totally under supported from a research perspective. So this is from the NIH, not the NHR that Oliver was talking about, the NIH. So this is coming from the US. And for example, for type 2 diabetes, where I said this is similar effect on the economy, the US spends about $35 each year per person affected by endometriosis. For endometriosis, person with diabetes, whereas when it comes to endometriosis, it's less than $1. So a significant difference, even though it has a same or similar effect on the economy. Now, this is something you may have seen very recently in the news. Actually, last week, I think it was last week, it was in the news, or the week before. There was an all-party parliamentary group looking at endometriosis and the effects it has and where the problems still lie. And this report was published, and you can find this online. If you go to Endometriosis UK, there's a link to that. Also, if you go to our website, we will put it on, I think, after tonight as well. So this report is about 70 pages long. It's a report of about 1,000 responses from women with confirmed endometriosis in the UK. So some of the things to take back from this is that about 58% visited the GP over 10 times before anyone thought about endometriosis or dealt with this appropriately. 21% visited doctors in hospitals 10 times or more. So it's not that the GPs are the problem necessarily only, but in the hospital, the same thing. 53% went to A&E, and a lot of them multiple times. 95% of women felt that endometriosis negatively impacted their well-being, and 81% said it impacted their mental health. And especially during current times, even more important, 38% were worried about losing their job. So what is coming out of this report? There are 4 recommendations. One is a commitment to drive down diagnosis time, so something that we're talking about tonight. One of the things is to ensure access to appropriate care so that women are readily reported referred to specialists with special interest in endometriosis. This is very clearly stated in the NICE guidelines, that we can increase awareness, and that is not only in the medical field but also in schools, in the general population, and that there is a significant increase in the investment in research for women suffering, women and individuals suffering from endometriosis. So how can we diagnose endometriosis sooner? So here in Oxford, what we're trying to do is really focus on better understanding the disease. So we do this through teaching. As I said, with Endometriosis UK, we support teaching students, for example, in schools, but also overall by publishing, by going to the press as well. This is a public outreach that we often do. Here you see some of our PhD students who go out, where here they create a very nice DNA double helix, very sweet, as you can see. But we really try to get the news out that it's not news, unfortunately, but get the word out that endometriosis exists, and it is a significant, has a significant impact on lots of individuals. From a research perspective, so we have a very large research group looking at endometriosis, and a lot of collaboration is going on there. So one of our interests is to look at the genomic studies, so to understand whether there are genes that predispose women or individuals to develop endometriosis. We are interested in biomarkers, as I said before, to really ideally find a single marker or possibly a set of markers that will give us a better idea whether someone has endometriosis or not, and to better understand the pain as well in women who are suffering from the disease. And this can only be done with support, and we do this in combination with support from the NIHR, as Oliver was pointing out earlier, but also from funders like the Wellcome Trust, the MRC, the NIH in the US, World Endometriosis Foundation, but also companies as well, which I'll talk about a little bit later. Now, in order to do this, you can obviously have a lot of theoretical thoughts about this, but you need patient samples. And we're extremely grateful to our patients to donate samples when they undergo surgery, planned surgery, for this disease. So this is a study that's currently going on. It was unfortunately stopped during COVID, like a lot of other clinical studies, unfortunately, but it has been reopened now. So these are women who and individuals who undergo a planned laparoscopy because there was a clinical indication to do so. And the research nurses usually see them in clinic, or nowadays we also do this, we try to do this online. If patients are then interested in taking part in the studies, we consent them and make sure they are happy to give us biological samples, but also fill out a large questionnaire, so we understand we can correlate the molecular findings to their daily lives, to know how long have they been suffering from the disease, what type of symptoms have they had, which is very important to really understand everything about endometriosis. And then we also ask the surgeons, so me, for example, or my colleagues, to really very detailed fill-in questionnaires. What do we find? What did the disease look like? Was it more white lesions, more red lesions? Was it extensive or small? And this is all necessary to really get a full picture of the disease. And then we do follow-up surveys. So we ask patients then to send us back the questionnaires after 6 months and after a year or two, just to see also whether the treatment, that they have received has made any difference at all. So this is a fednox study, which is going on, and this is the successor of the previous study, which was called endox. So fednox actually also looks at fibroids in endometriosis, whereas endox was only endometriosis. And as you can see here at the bottom, endox has finished in June of last year, and we were able to recruit 800. It was actually 799 participants, and fednox is now going on, and we're hoping to recruit even more participants now because of COVID. We may have to reduce those numbers slightly, these expectations, because there's a huge backlog of patients, but we'll see what we can do, obviously. And again, we're extremely grateful for highly motivated patients to take part in this. Again, a gruesome picture, and again, too late before I told you, so I apologize. Again, what you should take away from this is that it's a heterogeneous condition, as I said before, which means that it has many different facets and faces. So you see red lesions, black lesions, adhesions here, so scarring. And again, we deal with this as one disease, which is really a big problem. And if you, again, look at the biomarkers that we had looked at, what we found when we did look at this more systematically, that all these different groups around the world had maybe 20 or 30 patients where they looked at a very specific marker, and they had their methods to do this, and they found, all right, in our group, this marker is elevated in patients with endometriosis versus controls. And that's good because then you can publish it. The problem is if you don't find a difference, then usually most medical journals will not take that, which is a problem. And a lot of research that has been done then is just lost and will never be published, and no one will know about it. The other thing was that there was no standard way of collecting and processing data and samples. So some people collected it at room temperature, and some people stored it at 4 degrees. And if you have any background in biology, you know that a lot of the samples are quite unstable, and therefore you need to have a standard way of doing it, because if you want to compare different studies, you can only do that if you have a standardized way. And that was a big problem in academia. And we've learned a lot from industry, where they have been doing these standardized procedures for a very long time, unfortunately not for endometriosis. So therefore, what we set out was a few years ago in collaboration with a lot of centers and leading together with Harvard in the US, was this project to harmonize the way we collect data and samples. So this is the WRF Effect project. WRF is the World Endometriosis Research Foundation. And we looked at all the evidence of how to do this best, and we published protocols. So every center in the world who works with endometriosis can have a look at this and really use the standardized protocols. So therefore, we're able to compare patients who are going through the same procedures and have had the same things done in London, in Oxford, in Boston, in Beijing, in anywhere in the world, which will allow us to really do large-scale studies, which is necessary because, as I showed you before, the disease is so different, and in order to find different subgroups, we need to have large numbers to really be able to find subgroups which then may benefit from specialists or special treatments as well, and diagnostic approaches similarly. So these, as I said, these protocols have been published, and as you can see here, we now have, I think, over 30 centers around the world who are taking part in this, which is fantastic because now we are starting to get very large numbers, and hopefully this will help us to identify better diagnostic tests and possibly treatments then as well in the future. So this, as I said, only works with collaboration, and we are doing this very extensively here in Oxford with different centers within the UK, but also throughout the world, which is really necessary because you get the best people around the world work together, and then hopefully something will come out of this. And as I said, at the moment, we're dealing with endometriosis as a single disease, more or less, and that is really a problem. We learned this from other conditions like breast cancer, from lung cancer, from other diseases, where you have to find subgroups, and this is called stratification, to really identify subgroups that have similar, that present similarly versus other women who have, or individuals who have the same disease, endometriosis, but have it slightly different. And then if we are able to find these subgroups, maybe then we're able to have a more individual treatment where we can say, all right, you are in this subgroup, and therefore you need this type of treatment versus that person over there who should have a slightly different treatment, which is very important to do. Now, if you look around online, you will find some companies who are offering already diagnostic tests for endometriosis. As far as I'm aware, most of these studies or these tests have been based on relatively small numbers. And one of the principles we have to understand is that if you do biomarker studies, for example, so if you have let's say a blood test that you think is worth, that is good enough to discriminate between patients with endometriosis versus those without, you have to test them in enough large group of patients. So this usually works by, obviously having a hypothesis. So you say, well, this is a marker that I would like to test. And then you do your pilot study, which is usually done in an academic setting. As I said before, all these little studies that were usually pilot studies. And then if you find something, then you have to replicate it in a much larger cohort of individuals. And only then, if you have still a positive signal, then you have to go to the next step and do a validation study, which usually means you use women or individuals, in our case, not only in your original data set, so not only, for example, here in Oxford, but you go out to collaborators around the world and see whether they can do the same thing in a large number of individuals. And again, only then, if the signal, the result is positive, then you can use it in the clinic. And if you do it before, it is confusing, and there's the danger that people get falsely diagnosed with endometriosis, or it's falsely said that they don't have endometriosis, and that is very dangerous. So you have to have very reliable large-scale studies really to do this. And I'm almost done now. So there is some information for women and individuals to actually for anyone to really find the latest evidence. This is the ESHRE guideline, which is freely available online. This is the last guideline from 2013, and we're, as we speak, currently looking at the newest evidence. The nice thing about this as well is that you have also a patient guideline, which is written in non-medical terms. And that is really helpful for a lot of patients. This is from the 2013 guideline. And again, we will try to do this in even more languages for the guideline that hopefully will come out. Well, realistically, it's going to be early next year then. So I hope you have a rough idea of what we're doing here in endometriosis, and I'm very happy to answer all your questions. Thank you.
Thank you, Christian. We do have a couple of questions that have come through from audience members. The first one is from Rachel, who asks, is it possible for polycystic ovary syndrome and endometriosis to occur together? And if so, how would that present itself?
That's a very good question. This could be part of our lab meeting, because this is exactly what we're looking for at the moment. We do see that, yes, and we do not know yet how common it is, but whether there is a connection there genetically, for example, or not, we don't know yet. But we do see patients with both conditions as well.
Thank you. And a question from Heather. As well as women not wanting to talk about their symptoms, does unconscious sexism in medicine account for delays in diagnosis?
I'm very certain it does. That is a problem. I mean, it's so multifactorial that, you know, if you start on the family side, so, you know, a lot of let's say women or individuals, you know, when they're young, they have painful periods, and, you know, they hear, oh, you know, I've had it, your auntie had it, your granny had it, so get on with it. You're a woman, so deal with it. And you know, I'm certain that not everyone who has painful periods has endometriosis, by far not. But if it is really affecting life significantly, there is something wrong, and that's not normal. And you know, then it's much, as I said, it involves society in general, the medical field, you know, starting with the GPs, but also, you know, with specialists as well. Sometimes gynecologists, they say, I don't think it's endometriosis, and it often is. And we really need to be better identifying it and thinking about it.
So if someone is experiencing symptoms that they think might indicate endometriosis, what would you suggest they should do?
So in the UK, it's always, you know, going through the GP, and, you know, most GPs are fantastic. And it does not mean that every endometriosis patient or patient who has a potential endometriosis needs to be seen by a specialist. You know, it's impossible to do that because there's so many women out there, and the GPs are, you know, usually excellent, or a lot of them are excellent to deal with the symptoms. Even, you know, if you came to a specialist straight away, we usually would say, well, you know, maybe let's do an ultrasound scan, and just to confirm that there's nothing significant out there, as in, you know, large cysts or signs of deep endometriosis where it may involve other organs. But the first line of treatment, even in a specialist center, normally is hormonal suppression, unless someone is trying to conceive, obviously. But the GP is usually the first approach. And if you have a GP who says, never heard of endometriosis, which is not true, but, you know, doesn't recognize it, then you may need to, you know, talk to him or her and say, well, then would you please refer me to a specialist center? And they'd have to. That's, you know, according to the NICE guideline, that's very clear.
Great, thank you for that. And are there any dietary adjustments that perhaps people could make if they're suffering from endometriosis?
Yeah, so there are, but it's not based on any proper old school evidence, as we would call it. So it's not that, you know, there have been studies where 500 patients were treated with, or only ate or drank this, and, you know, the other didn't do that. And that's a problem, because it's difficult to do those studies. Anecdotally, I must say, though, there are, when in clinic, I see a lot of patients who say, well, actually, I cut out, gluten, for example, or dairy, or certain sugars or so. And that is probably because, pelvic pain is probably much more complex than endometriosis often. And it involves other organ systems as well, the bowel or the bladder. And if you imagine that, all these things like endometriotic lesions, but also the uterus, the bowel, etc., they all have nerve endings that converge together in the spine and then in the brain. And they all may accelerate things as well. If you can take some of these out of the equation, then for example, by changing the diet, you may improve the pain sensation significantly.
Great, thank you. Now we've got quite a long question that's just come in, so do forgive me if I just read it from my screen. It seems period pain and period-related mental stress are often downplayed as just PMS, in inverted commas, thus may lead people to ignoring the symptoms. It seems that many gynecological diseases share the same symptoms too. Do you have any suggestions to people without a medical background to note when it's necessary to go to see a GP? And what key markers should they mention to deliver their concern without sounding like they're just whining about an ordinary painful period?
Well, it's very difficult to say. So it's not that, it's not that the GP has a kind of checklist that say, oh, this, and therefore, I have to send her here or there. I mean, again, most GPs are well, fantastic, and they deal with this appropriately. But I usually it's also difficult for me because I'm sitting in the easy bit in the hospital where, I get the patients who have already been screened by the GPs. But if you have, painful periods, if you have pain during or after sex, if you have pain, especially cyclical pain, emptying bowel or bladder, then there's a reasonable chance that endometriosis may play a role in this. Non-cyclical pain can also be due to endometriosis. So it's tricky. As I said earlier, what we do, or the GPs often do, is they treat patients with these symptoms with a pill if they're not trying to conceive. And we call this empirical treatment, which is almost like a diagnostic test. So if the treatment doesn't have a significant side effect, and pills can, like any drug, can have side effects, and patients are happy with that, it's probably fine. And so far there's no data to say that you're masking the symptoms, but in the background silently endometriosis is creeping up. At least there's no evidence so far about this.
Great, thank you. And we've got two questions that both link to menopause and endometriosis. The first is asking whether there are any links between endometriosis and early menopause. And the second is, if someone has been greatly affected by endometriosis and is past the menopause, do you see them suffering from any residual problems, or might there be new problems that they would suffer from in that sort of new part of their reproductive life?
Yeah, excellent question. So we always talk about endometriosis as a disease during reproductive age, and it's the majority of women who are during this phase who suffer from endometriosis. Coming back to the effect of endometriosis on the ovarian or on premature menopause. So as you know, or as you may know, women are born with their eggs in the ovaries. Mm-hmm. And we're talking millions usually. So by the time a woman is born, there's about roughly a million eggs in the ovaries. By the time she hits puberty, there's maybe 300,000 to 400,000 left. There's obviously variation. And then she goes through them in her reproductive life cycle. And by the time she hits menopause, which in the UK is about 50-51, most of these eggs are then gone. But it also shows that the vast majority of eggs die off naturally. That's very normal. We do see that endometriosis per se, and probably as much as we can tell, endometriosis cyst, not cyst in general, but endometriosis cyst may have a negative impact on the number of eggs in the ovaries on its own. But what's even worse is repeated ovarian surgery because no matter how good of a surgeon you are, you always take a little bit of normal ovarian tissue away as well. And probably the wound healing after this surgery also, has a negative impact. So we know that the ovarian reserve goes down. So I think both naturally, as in probably ovarian endometriosis, but also us as surgeons can have a negative impact on that, and that could potentially bring the age of menopause forward. Second thing, effects of or the symptoms after menopause. So as I said, it's an estrogen-driven disease, and obviously estrogen levels drop significantly when menopause comes. And a lot of women are much better in menopause. But as chronic pelvic pain may have developed throughout the years before, it may be that the pain that is experienced in menopause, or it's possible that women have experienced a chronic pelvic pain syndrome that is not very much hormone related anymore, and that can carry on into the menopause where estrogen is not a big factor anymore. So it is possible that this happens in menopause as well, but I would say the vast majority of women with endometriosis are better when the estrogen levels are low, i.e. during menopause.
Thank you. Now, we have just slipped over time, but I can squeeze in perhaps one more question. And this one includes a three-letter acronym, which I'm going to have to ask you to explain. But is a double dose of POP a safe long-term management for endometriosis? Also
a good question. So POP is the progesterone-only pill. So as most of you may know, there are two different sorts of pill: the combined or contraceptive pill, which is estrogen and progesterone, and then there's the progestogen or progesterone, some people say, only pill. Now, what we often do in patients with endometriosis, but also in patients with chronic pelvic pain where endometriosis may play a role, is we try to stop the periods. And that may be doable with the mini pill or progesterone only pill and as a single dose. But sometimes it doesn't work with a single dose. And sometimes what we say is, well, actually take a double dose to really, give you enough hormone levels to suppress your estrogen, your own hormone levels and the endometriosis, and therefore also the periods. Now, how long can you do that? We know that the pill per se, and that's any pill, increases the risk of breast cancer. Over 10 years, it's about, if I remember correctly, 20 to 30% increased. And it goes away again when you stop the pill. It reduces the risk of ovarian cancer, and I think one of the other cancers as well, I think bowel cancer, but don't quote me on that. So it depends. So usually, you always have to balance the potential risks with the potential benefits. And if it really helps, you're probably okay on it for a longer time. But I don't think that we have long-term studies yet to say, a double dose mini pill, progesterone only pill is really safe. But we do it because we think it is probably safe enough.
Great. So it really does sound like it's a real balancing act with that one. Well, thank you, Christian, for such an interesting talk this evening. And also thank you to Oliver for his introduction earlier on this evening. It is time for us to end now, but all the events this year have been free for you to book, but we do like to give people the opportunity to support the festival, and we do very much rely on the support of our sponsors and our donors. So if you feel that you would like to put your hand in your pocket and give us a few pennies, that would really help us to bring the festival back to you next year, our 30th year, and hopefully, touch wood, we will be able to meet you in person. But thank you once again to Christian and to Oliver for this evening, and I will see you at the next event in half an hour.